Good evening, and thank you for joining the Ohio Chapter American Academy of Pediatrics webinar focusing on parental vaccine hesitancy. This webinar will be recorded and housed on the Ohio AAP website. If you haven't already done so, please take a moment to complete the pre-survey. The link is included in the chat box. Following this webinar, we will be sending post-survey information along with instructions on how to obtain your 1-hour CME. Please mute your line so that we do not have any interruptions for the recording. Please use the chat feature to ask any questions or provide comments throughout the presentation. You may also go off mute at the end of the formal presentation to ask any questions. Our speaker today is Ms. Christy Vickers. Ms. Vickers earned her Master's of Science in Nursing from The Ohio State University in 1998. She has worked as a pediatric nurse practitioner in both private practice and public health settings. Ms. Vickers currently serves as a full-time nursing faculty at Ohio University Zanesville, where she provides instruction in the areas of pediatrics, pharmacology, and community health. Her interest in childhood immunization started several years ago through her work with Ohio AAP's Maximizing Office-Based Immunization, or MOBI program. As a doctoral candidate at Northern Kentucky University, Ms. Vickers has collaborated with the Ohio Chapter American Academy of Pediatrics to explore parental vaccine hesitancy and evidence-based strategies to address this challenge. She holds membership in Sigma Theta Tau International Honor Society of Nursing and the National Association of Pediatric Nurse Practitioners, including the organization's Immunization Special Interest Group. And with that, I'll turn it over to you, Christy.
All right, thanks, Lori. I appreciate the opportunity to present to you all today on the area of pediatric care that I am very interested in, but also carries some concern for it being threatened currently. Before I begin, though, I would be neglectful if I did not express my sincere gratitude to Lori Wendland, Dr. Rebecca Brady, and the entire Ohio AAP organization for supporting my doctoral project. While immunizations are considered one of the greatest public health achievements of all time, there is growing perception across our country that vaccines are unsafe and unnecessary. Many of you have likely encountered this in your own practice. Vaccine hesitancy threatens the progress we have made in eliminating and reducing many infectious diseases. Through my doctoral work, I've explored evidence-based strategies to promote vaccine confidence and acceptance. I would like to share some of these strategies with you today, and whether you work with families through scheduling appointments, providing phone triage, offering vaccine counseling, or administering vaccines, you have a role in promoting a culture of vaccine confidence and acceptance within your agency. The following topics will be addressed during this presentation. I will define parental vaccine hesitancy and explain the significance of the problem. Primary factors contributing to parental vaccine hesitancy will be identified, followed by an overview of best practices to address this challenge. And then lastly, legal and ethical issues related to vaccine refusal will be outlined. To effectively address vaccine hesitancy, it's important to first recognize and understand how it's been defined. The World Health Organization's work group of vaccine experts convened and concluded that vaccine hesitancy refers to a delay in acceptance or refusal of vaccines despite the availability of vaccine services. They further concluded that vaccine hesitancy is complex and context-specific and varies according to time, place, and vaccine of interest. Now, I don't know about you, but when I hear those qualities or defining characteristics of vaccine hesitancy, it sounds very technical, but what does it mean for us as we practice day to day with parents and in interface with them regarding their vaccination concerns? And to put this into context for you, imagine, if you will, that parent who you are discussing those pre-kindergarten vaccinations, those vaccines that are required for that child at 4 to 6 years of age. And it's likely at that point in time that the parent may accept and receive all of those vaccines for their child without question. But maybe later that fall, when the child is in for a visit and you mention the influenza vaccine, it may be declined. Or even later into adolescence, when you mention the HPV vaccine, you find that the parent has several concerns. So you can see the variability and the context of this changing based on the type of vaccine that is being mentioned and perhaps the timing. Recent trends demonstrate that vaccine hesitancy is on the rise. In fact, the World Health Organization has recognized vaccine hesitancy as one of the top 10 global health threats. A 2019 national survey revealed that hesitancy toward routine childhood vaccines existed in about 6% of the parents surveyed. 1 in 8 parents expressed concern about the safety of vaccines, and only 1 in 4 parents believe the influenza vaccine to be effective. An immunization assessment by the Centers for Disease Control and Prevention in March 2020 found that more than 1/3 of our country's children between 19 and 35 months of age were not following the recommended immunization schedule. Vaccine hesitancy presents a threat to our communities. When vaccination coverage rates fall, we lose our protective herd immunity. We then no longer have enough people in a community immune to a disease to make the spread of it unlikely. As a result, children and communities are placed at risk of potentially life-threatening diseases. Now, when enough people are vaccinated against a contagious disease, they provide protection for those who aren't vaccinated. This effect is known as herd immunity, sometimes referred to as community immunity. This is helpful because herd immunity eventually leads to the eradication of diseases and helps those who are not able to receive vaccinations, maybe for a medical reason, such as immunosuppression or chemotherapy. This simulation shows how a contagious disease passes through different populations when varying percentages of its people are vaccinated. The percentage of people who need to be immune to achieve herd immunity is not constant. It varies by the particular disease. For an example, to achieve community protection or herd immunity against measles, approximately 95% of the population need to be vaccinated. The 2014-2015 Disneyland measles outbreak and the more recent rise in measles cases in 2019 reflect the importance of maintaining adequate immunization coverage rates. In 2019, we experienced outbreaks of measles across 31 states with nearly 1,300 cases being reported that year. Now, this was the largest outbreak since 1994. And interestingly, the cases occurred largely in under-immunized, close-knit communities and international travelers who were unvaccinated. Researchers are estimating that community protection against coronavirus will require at least 70% of the population to be immune. And to date, we are falling short of this benchmark. I think we most currently sit at about 40% of our population immunized. As depicted in this figure, there is marked disparity in the coverage rate of the seasonal influenza vaccine compared to other childhood vaccines. So when you look at this graph, you can see most of our other childhood vaccines kind of cluster around a coverage rate of 75 to 90%. And this includes DTaP4, IPV3, hepatitis B, Hib, pneumococcal, vaccine, MMR, varicella. And then as we look at influenza, however, the vaccination coverage rate for that vaccine is residing right around 47 to 56%. This is looking at birth cohorts, not reporting years, birth cohorts 2014 through 2017. We continue to see vaccine hesitancy and under-vaccination across all age groups, as similar low immunization rates are also documented among Ohio teens with the HPV vaccine. When the Tdap and meningococcal conjugate vaccines had coverage rates above 90%, the coverage rate for at least one dose of the HPV vaccine was only about 70% across males and females. This is even less when we look at the up-to-date rate for the HPV vaccine. This slide and the previous slide suggest that non-school mandated vaccines or daycare attendance vaccines are not as readily accepted. Now, whether this is a factor of how we as healthcare providers explain the vaccine to parents or how they interpret the idea of a school mandated or daycare attendance vaccines really is unclear, but likely a combination of both. Acceptance of vaccination is our ultimate behavior that we're all hoping and looking for. However, as researchers have studied this phenomenon, they have found that the decision to accept or refuse a vaccine is a rather complex decision-making process and is influenced by a wide range of factors. The 3 C's model of vaccine hesitancy attempts to describe some of the determinants of vaccine decision-making. This model considers confidence, complacency, and convenience. Confidence encompasses trust and how willing the parent is to rely on the expertise and advice of someone else. This takes into account the parent's attitudes and beliefs about the effectiveness and benefits or safety of vaccines. It considers the perception of the parent regarding the system that is actually delivering the vaccines. What is their perception of how reliable and competent we are as a healthcare staff? And it also considers the motivations of policymakers who decide on which vaccines should be mandated and which are needed. We have seen this more recently emerge or come under attack with the COVID vaccine and some of the public perceptions regarding conspiracy theories. Social and entertainment media and the parent's social network are also important influences. Vaccine confidence may also vary among certain racial and ethnic groups. A study exploring these differences showed that African Americans had lower trust in the government's role in vaccination compared with whites. And another study showed that African Americans were more likely to seek information from websites or significant individuals within their social support network, specifically churches. If the healthcare provider, however, shared a similar racial, ethnic, or cultural background, the level of trust was higher based on this kind of common ground that was shared. Vaccination complacency exists when perceived risk of vaccine preventable disease is low and vaccination is not deemed a necessary preventive action. In this instance, vaccine hesitancy has become an outcome of our own success. We have effectively eliminated many diseases to the point that the threat of disease becomes less in a person's mind than the risk associated with a particular vaccine. As healthcare providers, we also have fewer stories to share about cases of these diseases. And this is actually great news. It's our purpose for giving or administering vaccines. But as we will discuss later, these personal stories can be very influential in motivating parents to accept a vaccination. So when we're not seeing these diseases occur, we have less stories to share about the benefit, and the perception of the disease threat is, again, less than the fear of the vaccine risk. Vaccination convenience considers the availability, affordability, and accessibility of vaccine services. Providing services that are both convenient and comfortable from the perspective of our patients and families is important to gaining vaccine acceptance. If a vaccine requires multiple or lengthy appointments or at an excessive cost in terms of time or money, these barriers may contribute to vaccine hesitancy. Some of you may have experienced this in situations where the meningococcal B vaccine may not be available at your facility. So the patient is referred to maybe the public health department or another community agency to receive that particular vaccine. Having to take the adolescent to an additional appointment may result in that patient not ever receiving the vaccine. When we talk about factors related to convenience resulting in vaccine hesitancy, the impact of COVID must be considered. The pandemic has created, as we've all experienced, substantial disruption to pediatric outpatient medical care. A combination of parental fear regarding disease exposure and increased telehealth services resulted in a dramatic decrease in pediatric and adolescent vaccine orders during the spring and summer of 2020. And existing healthcare disparities within racial and ethnic minority groups further increased during this time period. To facilitate parental confidence and trust, overall in the healthcare delivery system, parents need reassurance that the provider's office is open and safe. Offices should employ strategies to separate well visits from sick visits as much as is possible. And many of you are likely already scheduling well children in the morning and maybe ill children in the afternoon. Placing patients with sick visits in different areas is an additional measure to promote a safe office environment. And offices might also reduce crowding in waiting rooms by asking patients to remain outside until they are called into the facility for their specific appointment. Adhering to infection prevention and control practices and making these very transparent to families, specifically in relationship to COVID, is equally important. Offices might also explore totally new approaches to appointment scheduling and vaccine delivery. This might include immunization-only appointments or maybe back-to-school immunization clinics. Ensuring that families who have a gap in insurance coverage, those who may be experiencing job loss or have a gap in their insurance due to the pandemic situation, we need to identify those individuals and have ways to make appropriate referrals for them for assistance, and make sure that they are aware of the Vaccines for Children program, so that cost of vaccines is not a barrier to administration. And lastly, following the catch-up immunization schedule when children fall behind will promote improved immunization rates as we move beyond the challenges of this pandemic. And yes, we hope that in the near future, the pandemic will be something that we view in our rear view mirrors. But as we look ahead, it is my hope that we can come on the other side of this pandemic and have maintained or even improved our immunization coverage rates. The decision to vaccinate is not an all or none phenomenon, as what some of us might have once thought. Rather, it's better depicted by this continuum. Acceptance of vaccination is the norm in most populations globally. That's the good news. Hesitancy does exist, though, and is set on a continuum between those that accept all vaccines with no doubts to complete refusal with no doubts. Vaccine hesitant individuals are this mixed group in between these two extremes. Remember, though, just because a parent accepts all vaccines does not mean that they have done so without any doubts. The number of totally unvaccinated children is relatively small, less than 2%. But this is worthy of our attention still because this number is on the rise. And we'll talk a little bit more about refusals toward the end of the presentation. As healthcare providers, we have the potential to make the greatest impact within those who refuse some, delay some vaccines, accept some, but do so with doubts. Parent surveys have shown that most parents have overall positive attitudes about vaccines, but need more information to feel confident in their vaccine decision. Most parents, as you've probably witnessed, genuinely desire to make a wise vaccine decision, but they want to feel confident in the choice that they make. As those working with children and families, how do we then create a culture that's promoting vaccines? Based on my review of current literature, I would like to propose a plan that involves activation of the 6 Ps. We must first pursue vaccine-eligible children to capture those in need of hearing reliable, important vaccine information. And as these children and families are served, we need to make certain that vaccine promoting messages are heard from the start of the interaction with that family to a discharge. Part of this involves a presumption of vaccine acceptance through a strong recommendation, as well as preparation for the inevitable questions and concerns that will be expressed. Our ultimate goal is to protect with vaccines whenever possible. And here again, you can contribute to this culture of vaccine promotion. And we'll take a deeper dive into each of these areas in the following slides. The first step in this process is addressing vaccine hesitancy is identifying or pursuing vaccine eligible children. We need to have knowledge of our patient population and who needs vaccines, who's behind on immunizations, in order to, have and hold those very important conversations. Institution of a formal reminder and recall system for patients can ensure that you actually interface with parents who need to hear that important vaccine information. Setting up prompts within the electronic health record can also provide a valuable reminder to providers to assess a child's vaccination status at every visit, and hopefully this will help to avoid missed opportunities. Even if the parent doesn't agree to the vaccine at that particular visit, you have at the very least provided additional vaccine information for their consideration. And scheduling follow-up immunization appointments before the child leaves the office will offer ongoing assurances that you will have continued contact with that patient and family. Guaranteeing that everyone within the office is on board and consistently offering vaccine promoting messages really cannot be overstated. Regardless of your role or position, you have the potential to contribute to the parent's doubt or build the parent's confidence about vaccines. To gain and maintain parental confidence in vaccines, all messages within the practice must align with the goal to vaccinate. To establish such a platform, attention may need to be given to address staff fear or questions regarding vaccine efficacy and safety. I find it perplexing when I read reports regarding vaccine hesitancy among healthcare providers. We cannot expect to build confidence in those we serve if we don't first feel confident about vaccines ourselves. Research demonstrates that education and support from colleagues goes a long way and can really facilitate healthcare provider confidence. So I guess I challenge you to take a look inwardly at yourself as well as your practice as a whole and seek to identify any gaps in this area. Does any staff fear and hesitancy about vaccines exist? And if it does, this isn't a time for fault finding, but just recognizing where that gap is and targeting educational efforts and support in order to kind of shore up that commitment to vaccination and to make sure all messages align. Here again, I cannot overemphasize the importance of making sure everyone within the office is committed and in agreement with the office's vaccine promoting message. Parents who have a vaccine concern may merely need someone to agree with them to strengthen their opinion. A divergent view from even one member of the healthcare team might be what the parent remembers most, and research is available to support this, that a parent, before they even encounter a healthcare professional, they are inundated with messages on Facebook, social media, family, websites. So they have likely already developed their opinion about vaccines. And if they are already holding concerns, research shows that having even one person kind of confirm that worry or concern will strengthen that in their mind, and all other vaccine positive details may be discounted. Two different approaches to vaccine counseling have been discussed in the literature. A participatory approach takes on a more conversational style, with the provider asking what the parent thinks about vaccines. An example of this might be stated as, what do you want to do about your child's vaccines today? This approach seems to be more aligned with the shared decision-making model often encouraged for many aspects of pediatric patient care. With vaccine discussions, however, such an approach is not as beneficial. A presumptive approach, on the other hand, makes a strong statement regarding the expectation of vaccines being given. This statement presumes acceptance of the vaccine from the onset. You can see this approach exemplified when a provider states, your child is due for 3 vaccines today, the MMR, influenza, and varicella. Research demonstrates that a presumptive approach fosters greater vaccine acceptance when compared to participatory language. Bundling vaccine recommendations in a manner that conveys the same level of importance for each vaccine is also helpful in promoting acceptance of all vaccines that are due. You can see the statement that's listed, your child is due for 3 vaccines today, MMR, influenza, and varicella, presumes acceptance, whereby a statement such as, your child needs MMR and varicella for daycare, and you could also think about the influenza vaccine if you wanted. The very way in which that vaccine recommendation is delivered shows less importance to the influenza vaccine compared to the MMR and varicella, and could most certainly impact a parent's choice to vaccinate with all 3 or just 2. The strong recommendation from a trusted healthcare provider has been found to be the most compelling factor to gain parents' agreement for vaccination. Pediatric providers must leverage the influence they hold. Even with all the media and internet influences, parents place the most trust for vaccine information in their child's provider. Thus, your role in advocating for the health and well-being of children is significant. While a strong vaccine recommendation is important, presuming with understanding is equally warranted. A dismissive approach has been shown to erode trust and result in decreased parent satisfaction with the visit. The key is really listening to the parent and striving to answer and address what is asked. Providing more than what the parent is really wanting to know may be counterproductive. Likewise, avoiding or discounting important details that are of concern to the parent also proves frustrating. Research has shown parents feel better informed and more satisfied with the discussion when they receive straightforward answers to their questions. Anecdotes often win over fact when discussing the value of vaccines with parents who are hesitant. Sharing an experience of a child who suffered from a vaccine-preventable disease may persuade a parent to accept a vaccine more than merely relating scientific evidence or statistics. So what does that mean for you as a provider? If you have an experience of a child who, endured a vaccine-preventable disease, share it. You will find that for many parents, these stories will resonate very heavily with them. And in this instance, the story is not a substitute for vaccine facts. Rather, the narrative is a way to illustrate the data in a more meaningful and memorable way for the parent. As you share these stories, though, it's really important to avoid the use of medical jargon. And additionally, be cautious about fear tactics. These fear tactics have been quite effective with anti-vaccination messaging. We can all kind of think in our minds of some of the fear tactics that have been promulgated. However, more often than not, when the research has looked at fear tactics, the research has demonstrated that these are counterproductive in reducing vaccine hesitancy. When working to clear up misinformation, be wary of also overstating your point. Adults will generally remember the gist of a communication, not the entire dialogue verbatim. So it's often helpful that when you've shared your anecdote or you've shared your story to kind of summarize it by saying, so the take-home message is, or the bottom line is, I recommend the MMR, varicella, and influenza vaccine for your child today. They are each very important to preventing disease. At times, you may have a parent who is more data-driven, and you can probably think about that parent who you have engaged in a conversation who has maybe a science background and they are just more interested in the science and the data. In this instance, sharing some science behind the vaccines or some statistics may more appropriately speak the language of that parent. The key again is attentive listening and discerning the level and the area of the concern of the parent so that you can target the language that you speak and you can target the information you provide to best resonate with the parent's concern. Not all vaccine discussions will end with a vaccine being given. However, closing the visit with at least one agreed upon action indicates progress, and we need to celebrate those successes, however small they are. The vaccine hesitant parent might agree to check out a reliable vaccine website, or the plan might be to just revisit that vaccine discussion at the next patient encounter. Regardless, an opportunity to vaccinate the child at some point remains a possibility. And our research shows that when providers hold these open dialogues with parents about their specific concerns, some vaccine hesitant parents eventually accept vaccines. The case approach is a model to assist providers in communicating with parents who are hesitant about vaccines. Ironically, this communication process was developed by Allison Singer, an administrator at the Autism Science Foundation. You can find more details about this approach on the American Academy of Pediatrics website. Now, this particular information is probably most relevant to those nurses and providers who are actually providing the vaccine counseling to parents. The first step in this process is corroborate. And this is the time when you can acknowledge any concerns by the parent and really set the tone for a respectful discussion. It's also helpful to find common areas of agreement, even if the parent's current position regarding vaccines is not one of those areas. And, I understand that it's often hard or challenging to find that common area of agreement. Sometimes a parent's view about vaccines are so different from what we know that, it can be difficult. But you may find that common ground just based on saying something like, I can really see that you're interested in making the very best decision for your child. I can see that you've sought out some information and some sources, and it was really important to me as a parent to make the best decision. And I'd like to talk to you more about that. So finding that common ground and setting a tone for a respectful conversation is really important. About Me allows you to establish yourself as the vaccine expert. Remember the leverage that you hold and the influence that you have with the parent, because this is the point where you can share your experiences as well as a personal story. You might also need to redirect the parent from an unreliable vaccine resource and provide a rationale for your position. Respect does not mean agreement, so redirecting misinformed parents is important to providing the best possible care. Combining an anecdote with science is motivating for some parents. But remember, data overload can be problematic. Try to keep the facts or the statistics to the parent's specific area of vaccine concern. Providing too many details, again, can be counterproductive. And avoid myth busting. I cringe a bit as I say this and share this with you out loud, because it was not so long ago that I was speaking to a community group regarding vaccines. And I think I entitled the presentation, Untangling the Myths and Facts of Vaccines. But I wish I knew then what I have learned now, that myth busting can be problematic, because research shows that the very mention of a myth can often magnify it in the individual's mind, making the false information more memorable than the fact. The last step of this communication process involves explaining and advising. This is where you will offer your advice by restating your strong recommendation for vaccination. This is the time where it's important to kind of make your recommendation in a brief, succinct statement, providing them with that take-home message. Because communication is such a big part of the solution to promoting confidence in vaccines, whether you use the case approach that we just discussed, or motivational interviewing, I want to share some findings from a recent systematic review by Olson and her team. The way in which we frame or package our vaccine promoting message really matters. And as this research team found, storytelling and emotive anecdotes are very compelling. As these are shared, however, parents still need to hear that bottom line or gist. Stories without that bottom line, that takeaway message being clearly stated may be less effective. This research team also found that our tone matters. Like many tough conversations, studies show that humor is beneficial to reduce that kind of emotional reaction of some parents. And this is particularly true for parents who are hesitant about vaccines. It's probably less effective as far as humor when parents have already accepted vaccines, but humor used selectively can be helpful to just kind of diffuse some of the anxiety and emotional reaction of some parents who are very strongly opposing vaccines. Overall, enthusiasm when sharing vaccine information is received more positively. And so we need to be excited about vaccinating children, and we need to show that excitement and enthusiasm to our parents. You know, we're not likely to buy a car from the salesman who is not very excited about the vehicle that we are contemplating a purchase for. But in the same sense, we need to be excited about protecting children from these potentially life-threatening diseases. Another area of framing the message involves combining your pro-vaccination message with information such as breastfeeding or healthy eating. The literature has shown that these co-promoted behavioral messaging techniques can be really influential. And as we've already discussed, sharing science may be of interest for parents, but should be done with attention to avoiding medical jargon. Parents, you know, are able to understand the science, but they need to hear it without the medical jargon. And so we need to be careful that when we're sharing selective facts about vaccines, that we avoid the use of jargon. And again, expert opinion is powerful, so leveraging that influence is very meaningful. To summarize, or to provide you all with the takeaway or gist of communication considerations, it's important to recognize that proactive and targeted communication is needed. While bundling of a vaccine recommendation is a helpful strategy, there comes a time when a parent may need a specific vaccine risk discussed. The most successful and satisfying vaccine conversations involve listening, learning, and advising. And shall I repeat and re-emphasize the importance of listening? Your knowledge and experience as a vaccine expert are important, but will likely not be the only strategy necessary to gain vaccine acceptance. Personal stories about vaccines are often more effective than scientific evidence to gain vaccine acceptance. And as we interface with parents, we need to present immunization as the social norm. The ultimate goal, what we are all seeking to achieve, is to protect infants, children, and adolescents from each and every vaccine preventable disease according to the Centers for Disease Control and Prevention recommended immunization schedule. And this, as you know, is updated annually and approved by the Advisory Committee on Immunization Practices. Following this protocol involves offering each vaccine as soon as it is due, regardless of the vaccines or the number of vaccines to be administered. And I would also add that we need to advocate for vaccines as strongly, whether they are mandated for daycare or school attendance or not. Referring to the catch-up immunization schedule when necessary and adhering to the guidelines outlined by the Advisory Committee on Immunization Practices, general best practice guidelines, is a critical aspect of professional responsibility as a vaccine provider. Each link in promoting vaccine confidence and acceptance is important. All members of the healthcare team have a role and a responsibility in this process. And remember, a break in even one link in this chain, a divergent or wavering view from that vaccine promoting message that we want to have, that break in the chain is still a break in the chain and has the potential to contribute to a parent's doubt or concern about vaccines. So I encourage you to individually and collectively kind of reflect on your office setting and your practice and try to keep each link in this chain strong and active. Written pamphlets or brochures can be used to complement the information you share during your vaccine discussions, but should not be a substitute. The research is clear that parents really prefer face-to-face, dialogue-based interactions, vaccine discussions with that trusted immunization provider. Whatever written communication tool you use, however, the material needs to be thoughtfully selected, keeping in mind that healthcare literacy is often a challenge. The Ohio AAP offers these helpful brochures to target the position of the parent. And these brochures are color-coded, whereby the green brochure addresses and thanks the parent who has accepted vaccines. But remember, as I mentioned earlier, just because a parent accepts all vaccines does not mean that they did so without maybe a little hinge of doubt. And so this particular brochure can be really meaningful to just providing extra support to that parent and allowing them to feel more confident about the decision they made to vaccinate their child. The yellow brochure might be used for a parent who has accepted some vaccines, but might have a concern about a particular vaccine and has opted to delay vaccination of that particular vaccine. The red colored brochure is appropriate for the parent who might currently be refusing all vaccines. So as we talk about vaccine refusal, let's take a brief look at the characteristics of outright refusers. These infants and children are unimmunized largely because their parents lack trust in medical providers and hold high safety concerns regarding vaccines. This really speaks to the importance of engaging in respectful conversations and listening actively and attentively to build trust and hopefully eventual vaccine acceptance. Less than 2% of parents firmly refuse vaccination. While this number is relatively small, you will recall from earlier in the presentation that this number is rising. And if you encounter a parent who firmly refuses vaccination, here are some helpful steps to follow. As challenging as it might be, take steps to initiate a conversation and employing some of the communication techniques and strategies that we've already discussed can be helpful. Listen carefully to the parent's concerns, finding any common area of agreement when possible. redirect the parent to reliable vaccine resources if necessary, and overall, keep the conversation brief. This will help to avoid kind of entering into that we-they battle that generally does not end well. And most importantly, demonstrate an openness to future vaccine discussions with that family. The American Academy of Pediatrics refusal to vaccinate form provides a template and guidance for medical providers to document parents who refuse vaccinations after discussion. The American Academy of Pediatrics recommends continuing to provide care for the children of families who refuse vaccinations, in the hope that with further education, it will allow the child complete or at least partial vaccination. Careful consideration must be executed before dismissal from the practice solely for vaccine refusal. The AAP site offers some excellent guidance on coding of visits and ways to actually capture the valuable time that you spend in vaccine counseling, specifically with those who are refusing. In only rare instances will vaccine refusal constitute actionable medical neglect requiring referral to Children's Protective Services. An example of this might be a parent who refuses the rabies vaccine for a child who is bitten by an animal confirmed to have rabies. Refusing a vaccine such as the HPV vaccine, while we deem it very important, would not rise to the level of concern of actionable medical neglect, because cancer development is possible but not able to be predicted. Ensuring that parents and office staff have access to reliable vaccine information is vital. The Centers for Disease Control and Prevention, the American Academy of Pediatrics, both our Ohio chapter and national, and the Immunization Action Coalition provide invaluable resources. And I encourage you to check out these sites if you have not done so already. As we talked about stories having impact, you may not have your own story to tell, but the forgotten story listed here from a Texas Children's Hospital often strikes a chord with parents. And these are just a compilation of stories providing real life examples of the decision not to vaccinate and the impact that it has had on families. So in conclusion, vaccine hesitancy is a growing concern and prevents children and our communities from achieving optimal vaccination rates. Creating a vaccine promoting culture within each practice, from the initiation of that first appointment through discharge of that patient, is vital. Parents need to feel their concerns are heard, and they need to experience a time in which their questions are answered. And remember, a solid recommendation from a trusted provider is extremely powerful. The challenge is real, but well worth the investment of time and effort. Thank you for the work you have done, for the work you continue to do, and your continued investment in protecting our children and communities. I thank you again for your time and attention, and I do believe we have a few moments remaining if there are any questions.
Thank you so much, Christy.
Sure.
If you have any questions, feel free to type them in the chat box, or you can go off mute and ask Christy directly.
And as we are waiting for any questions that might appear in the chat, If you would like to have any additional resources, the Ohio chapter of the American Academy of Pediatrics has a wealth of immunization related resources, and you can contact Lori Winland, and her email address is there. If you have questions for me after this presentation, and contact Lori, she'll be happy to connect you with myself. I've included my references, and those, as well as the whole slide presentation, will be shared on the Ohio AAP website. And I would also appreciate completion of the post-program survey, if you would be so willing. This is a completely anonymous survey. The QR code is listed here. You can use your phone camera. The link will also be provided, and you will be receiving an email in the next 24 hours with information with the link for the post-program survey, as well as how to obtain your CME credit. Any questions?
Well, thanks so much, Christy, and thanks to everyone for joining us this evening. We appreciate your attendance, and if you can go ahead and complete the post-program survey, and like Christy said, we will be sending out not only the information on how to obtain your CME, but the recorded webinar link, as well as the slides. So those should be hopefully going out tomorrow morning once we get everything uploaded to our website. And if there's no questions, we hope you guys have a great evening, and thanks again for joining us.
Yes, thank you all.